Okay, good afternoon, everyone, and thank you for attending the fourth session of our fifth annual general meeting of Saudi Midwifery Group. I'm glad to invite Dr. Wafa from Iraq. She is a doctor of philosophy, PhD in nursing from the University of Baghdad College of Nursing. Also, Dr. Wafa, she is the head of Iraqi Midwifery Association, which is established in 2014. She's also the facilitator with the WHO workshop and the national nursing conferences. So welcome, Dr. Wafa, and thank you to be part of our annual general meeting.
Hello to all. Assalamu alaikum. Good evening. My name is Dr. Wafa Abdul Karim Abbas. I am from Iraq. At the beginning, I would like to thank the organizer of the 5th annual general meeting of Saudi Midwifery Group for giving me this opportunity to present my paper, and I wish all the success for this scientific event. The title of my presentation is The Challenges Facing Midwifery in Our Region. The Middle East has experienced one of the world's largest growth population over the past century, leading governments to struggle and meet the basic healthcare needs of their citizens. As we know, the Middle East region is defined by WHO as the following: Bahrain, Kuwait, Qatar, Saudi Arabia, Emirates, Afghanistan, Djibouti, Egypt, Iran, Jordan, Lebanon, Libya Arab Jamhuriya, Morocco, the Sultanate of Oman, Pakistan, Somalia, Sudan, Syrian Arab Republic, Tunisia, Palestine, and Yemen. One of the challenges in our region is that there is inadequate staffing and also inadequate infrastructure, as well as shortage of educated midwives who can inform their practice within current research, and also closing the gap between the current state of health and the target set by the government remains as a major challenge. The other challenges are the increasing women access to the quality midwifery service. This was as a focus of a global effort to realize the right of every woman to have the best possible health care during pregnancy and also during childbirth. The other challenges is the unclear identity of the midwives. So the fundamental issues faced by midwives is their unclear identity, buried among the multitude of cadres trained, employed, and empowered as midwives, despite lack of qualification according to the ICM International definition of midwife. The other challenges, we have different levels of midwives in our region. Several categories of health workers are identified as midwives in our region, including registered midwives, road midwives, community midwives, clinical officers, community health nurses, community health extension workers, and often traditional birth attendants, TBA. The situation of midwives in some countries in our region, it is a part of a wider debate on human resources for health. As example, the status of midwives in some countries is characterized by different levels of midwives. The other challenge is there is no job description in our region regarding midwifery. In most of our countries, midwives don't have a formal specific description. Sometimes there is job description, but it is not implemented in the clinical area. This will make their definition even weaker and thus allows a distinction between the role of midwives and nurses. The other challenge is the model of care. In our region, the model of care, it is medical rather than a midwifery model of care. The medicalization of the profession and the frustrating feelings of subordinate relationship toward the doctor or nurses, it is another challenge faced by midwives in our region who suffer from being led by other professions, not by midwives. The midwives are often perceived as serving in the role of obstetric assistant, not a midwifery profession. And also midwives are characterized by a lack of self-confidence, lack of autonomy, and low status. The other challenges is the stigma of being a midwife. The work of midwife carries a stigma in some countries. So it often exposed to burnout through working in a precarious time, also unsafe working environment where service quality is poor, not based also by evidence and compounded by the lack of service, such as a sound of referral system. The other challenges is absence of career planning and promotional prospects. Additional challenges, the role progression, including the absence of career planning and promotional prospects, and by poor condition of service, such as salaries and educational benefits. The other challenges facing midwife in our region, it is war and political unrest. In some countries, war and political unrest have led to the destruction of infrastructures and also the instability. Midwives are geographically isolated in separate practice settings, given the size of the country. Also, there is often little community support for midwifery service, justified by dissatisfaction with the quality of midwifery service. Commitment to strengthening nursing and midwifery have been provided over the years by the World Health Assembly and the Eastern Mediterranean Regional Committee. However, despite this high-level commitment, the region continues to face deep challenges in ensuring adequate nursing and midwifery capacity. Regardless of the indicators, midwives also face similar challenges in low status of women, gender issues, and workplace domination. In many of these countries in our region, childbearing women and their are currently experiencing unimaginable stress. unimaginable stress and hardship of the turmoil and trauma. The other challenges are midwifery educational programs. In most countries in our region, midwifery educational program, it is led by doctors or by nurses, but rarely by midwives. These are most of the challenges in our region. Thank you for your listening, and thank you for this opportunity to face these challenges in our region. And because when we are going to do our activity plan to strengthen midwifery in our region, we have to face all these challenges. Thank you to all.
Thank you, Dr. Wafa, for sharing the Iraqi midwifery experience. And I feel, and like you mentioned in your presentation, there is many challenges to go through, but I'm happy that it's established and there is association for midwifery in Iraq. First question is, what do you think we can learn from your experience of midwifery in Iraq? Dr. Wafa, I think your mic is closed. If you can open it because you are mute.
Yes. Sorry.
Hello, Dr. Wafa. You was hearing me or you want me to re-question?
You asked me about my experience?
Yes, if you want to share, thank you for sharing your presentation and your challenges for midwifery established in Iraq. And I'm happy that now there is association since 2014 defending midwifery and empower midwifery in your region. The question is, what do you think we can learn from your experience or midwifery in Iraq, or what's the most important power point in midwifery in your region?
Related to change the status of midwifery in Iraq or in our region, it has to have a plan, an activity plan. This plan, it has to be powered by a policy. So the policy maker who are going to support us to implement the plan of strengthening midwifery in Iraq and also the other countries in our region. Because in spite of all these challenges, we have to need the support of the policymakers for giving us the chance to to uprise the midwifery in Iraq and the region.
Okay, thank you, Dr. Wafa. Another question is, thank you for a very interesting talk. What is being done through the health authority to improve the status of midwifery in Iraq?
The establishment of a midwifery association, and also we are a group of people who are donate their work to support the midwifery.
Okay, so thank you, Dr. Wafa. If you want to add any comments, feel free, please.
Thank you. But related to midwifery, we have to have well-educated midwife. Their practice, it will be on a standard or ICM competencies, and also strong association. And the leader, it has to be a midwife, not a doctor, not a nurse. We respect all the other professionals. We can work with all the other professionals, but we have to lead midwifery by a midwife. Thank you.
Yeah, thank you. As you mentioned in your last challenge, that's the most challenge thing. It's any program for midwifery, it's led by doctors or nurses. And you need more midwives to be more qualified and to start nicely the program to teach midwives. So hopefully,
we have to start to upgrade the program. Well-educated midwives, strong midwives, who have the power to lead midwifery in our region. Thank you.
all the best for midwife Sarah, and hope soon you will have a very strong midwifery system. And I feel happy that you start already, and for all the best for the Iraqi midwife. And thank you to join us to sharing your experience. And this is the start, and the future it will be better.
Thank you so much. Wish you all the best.
Thank you. Thank you. Thank you. So thank you, Dr. Wafa. We will move for the next speaker. It's Dr. Ibtisam. Dr. Ibtisam, she is the assistant professor and vice chairperson. She's in Department of Maternity and Child Health Nursing in King Saud University Hospital. Also, Dr. Ibtisam, she's our treasurer actually of Saudi Midwifery Group. Welcome, Dr. Ibtisam, and her lecture today is how to sharing the experience of establishing the first midwifery bachelor degree in Saudi Arabia. Welcome, Dr. Ibtisam, and thank you for sharing this session with us.
Thank you so much. Hello, everyone. Good afternoon and good morning or good evening, everyone according to their region. Happy to be with you and very proud of, as a member of the Saudi Midwifery Group, very proud of what we get to this point. It's a very interesting and happy, and thanks for every speaker and who joined us today and yesterday and sharing their experience and informations with us. It's very informative sessions. So today I'm gonna talk about our journey in building the first Bachelor of Midwifery programs. And this is my outlines, and majority of my outlines, it's been covered by my colleague, Dr. Roa, welcoming session yesterday, and by Dr. Wafa just now when she elaborate on the midwifery profession situation in our region. So I'll go with it, through it, but just quickly. So before 2015, the only thing we have here in Saudi Arabia for midwives, it's just only limited numbers of midwives who are presenting in labor room in some of the hospitals. And those midwives are had an undergraduate diploma of midwifery, or the other scenario, we will see doctors and nurses in dealing with the labor and birth. As Dr. Wafa also elaborated, there was no job description, there was no scope of practice, there is no identified body for the midwives. Happily to say that in August 2015, Saudi Midwifery Group was established under the Saudi Society of Obstetric and Gynecology. From that year, 2015, up to 2020, there have been a lot going on, and I'm very proud of what we approach up to this day. So there was 2 temporary midwifery streaming midwifery committee established, one at the Saudi Commission for Health Specialists and one at the Ministry of Health. There was a directory book for the midwives released by the Ministry of Health. All the midwifery classification at the Saudi Commission for Health Specialists was revised. Now there is an identity body for the midwifery at the Ministry of Health, which is Dr. Aroa is the head of it. It's become, even if it's slowly, but the midwifery as a profession becomes noticed and recognized by some of the other medical professions. Saudi Midwifery Group conducts several midwifery-related events. So we celebrated the International Midwifery Day, and we had an annual meeting for every year from 2015 to 2020, which is now the 5th one. Saudi Midwifery Group become then a member of, during these years, a member of the International Confederation of Midwives. Saudi Midwifery Group signed several contracts with the different communities and institutions. And there is also a number of workshops that was conducted to improve the current midwifery skills and performance. What we have right now, or what's the midwifery courses or programs that we have in Saudi Arabia? We had or we have until now. So the undergraduate diplomas was all of them terminated. So there is no more undergraduate diplomas. We had before 2 years and 3 years undergraduate diplomas. What we have now is a postgraduate diploma that's under the Saudi Commission for Health Specialists, which is 2 years, and it's purely clinical, and it's conducted in the hospitals. And also we have a Master of Midwifery program, and it's 2 to 3 years according to the pathway. It's a coursework or it's a research. And of course, it's conducted in the universities, and it's considered to be academic. So why we need a Bachelor of Midwifery program? Dr. Ru'a elaborated in her introduction yesterday that one of the pillars for a strong midwifery profession is education. So there is a leadership and administration, and that's, I think we went through it very well, and think we have established a good base for us right now, and we need to go further, but we didn't come to the education part. And so that's one of the very necessary programs to be there, so we can have a continuity of the education for the midwives. Another reason is the number of normal midwifery and deliveries, normal deliveries in Saudi Arabia. So around 500,000 of births every year, 60 to 70% of them, it's a normal vaginal delivery, which means we need more midwives. The number of Saudi midwives currently, it's only 1,800. So we need around 10,000 midwives more to cover the need of this number of births. So that's mean we need a quick program, which is a Bachelor of Midwifery program. So we need to graduate more numbers of qualified, skillful midwives who can able to work independently in partnership with women. As I said, we need this program to have a continuous educational pathway for all midwives. So such as those who had an undergraduate diploma midwifery, they need to continue their education in midwifery so they can go further in their pathway. And it's a regional and international needs to have a Bachelor of Midwifery program. And I could say that because it was one of the priority in the strategic plan for the ICM Mediterranean region meeting in 4th of November when we conducted. It was the first item on needs that is elaborated by all countries, sorry, that we need to establish a well organized and well Bachelor of Midwifery program. And also it was just mentioned by Dr. Wafa. So in King Saud University, after we got the announced that there is a support from the Ashura member, Dr. Zainab, that we need, she said that we need an separate bachelor degree of midwifery from the nursing. And also we got the support from the Ministry of Education. So the start was in 2018. We built the first committee to develop a bachelor program of midwifery. And this committee didn't continue their work for several reasons, administrative reasons. So in 2019, again, reorganized the committee to develop a bachelor program for midwifery. And this committee continues to work in over 2 years. The committee member was having a different qualification in midwifery, ranged from professor to associate professor, assistant professor, and also specialist and lecturer. They all had a qualification in midwifery. Of course, we did benchmarking and referencing, and our base was an ICM guidelines in building midwifery programs. We also used as a reference some of the UK universities and Australian, South African, German. And of course, we follow the King Saud University curriculum policy and College of Nursing in King Saud University policy. The final result, we had we completed the program. So it's a 5 years bachelor degree program. The first year is a common year, which is shared between nursing and midwifery student. Then 3 specialized year in midwifery. And the last year is the internship year, which is, I mean, the rule of 5 years, it's something related to the university. And the program will be started under the College of Nursing in King Saud University as a separate program. The admission criteria was it's only open for girls for a cultural and cultural sensitivity issue, and it will follow the other all the requirements of I mean the GBA and all the requirements of the nursing college. Where are we up to now? The plan was to start the program next semester, which should be started in 1 month and so. But because of the corona and we couldn't reach the student and advertise well, we started advertising the program, but it didn't reach to the student very well. So it will not start next semester. And so we finished all the administrative process regarding entering the programs in the system, fixing all the number of hours and the prerequisite and co-requisite, course specifications finished already. We did 2 virtual meeting with the student in common year to advertise to the program. There is some of the modification come up when from the university dean of academic studies regarding fixing some courses, and also we did that. So the plan is to receive or to start teaching the program to the first batch of the Bachelor of Science in Midwifery in 2021, which is in the beginning of the academic year, which is in August 2021. What we need, or what we still need to work on, we need to advertise more of the program. And not all of the program, we need to advertise about the profession. We need to educate the community, because still there's a lot of students do not understand, and a lot of women do not understand what midwifery is and what's her role. There is a lot of confusion between the role of the nurse and the role of the midwife, and of course the OB-GYN. The right way to explain it is to follow the scope of practice that was released by the Ministry of Health here. And also is where the midwife should work. This is the most questions that we receive. Most of the students will ask, I will be working only in labor room. And so where she can work, what's her role, and to what extent she can continue her study. All these questions is still unclear for most of the students, and that's maybe limited the number of the students who apply for the program. So the future plan is to more education about the profession and about the program to the community, to the students, future students. So We have a lot of plans, but Corona is limiting us because it's not easy to approach, get to the student. And also is to have more staff, faculty, to teach the course. As Dr. Wafa also elaborated, we need to be led by midwife and teach, do the whole courses also by midwife. We have a good number, but we need more to make sure that we have a very strong base for our program. The third thing is ensuring a good clinical practice for the students later on, because we don't have what we are trying to produce by our program in hospitals and labor room. So, and I mean by that, the midwives are already there, not all of them having a postgrad diploma or master. So we that's what we're thinking is we can limit the, we'll not accept a huge number of students at the beginning, because we want to have release a very competent midwives. They will be able to teach the following groups and batches. So that's it for me. This is my email. And a truly special midwife, I remembered forever. And a truly amazing midwife is hard to find, difficult to part with, and impossible to forget. And that's what we were trying to impress in our students, that the role of the midwife is not something, it's not easy, but it's very memorable and affecting the woman's and baby and the whole family life. Thank you for listening.
Thank you, Dr. Abtisam, for this amazing introduction for the new midwifery program in Saudi Arabia. I think it's a great work, and it's a long way, and finally we achieved and we put the plan, and according to your effort and many others. Thank you too much for this happy news. And finally in Saudi Arabia we will have a bachelor midwifery Saudi's midwives for the future and for the benefit of mother and baby. My question is, there is because many even when I work, they asking how we can apply for this. Is it for everyone? What's the really requirement to go and to register to be a midwife?
Well, the program mainly will take from the secondary school. So the girls from secondary school will be applying for the College of Nursing and Midwifery, and they will take the common year. And in this state, of course, they will follow the university rules and regulations. I mean, regarding the اختبار القدرات and the percentage of they have and all this stuff. And then they will finish the common year with this nursing student, and there is and after that they will join the college immediately. So there is no, some of the students thought that if they did get a very bad scores in the common year, we will not accept them. As long as she finished the common year successfully, she will join the College of Nursing and Midwifery, and she can choose to study midwifery.
Either she will continue as a nursing program or the midwifery program.
Yes, she will choose one of them.
And how much, like the number of the first bachelor of midwives?
We were aiming to 20, because usually the groups at the university, especially for clinic, will take 10 students each. So we thought 2 groups will be more than enough to start with, to make sure that they get the perfect and the optimum training. But then we thought, okay, if it's 10, then we can go with 10 also students. But maybe because it's a second semester, so usually at the beginning of the year you can get more students, but the second semester usually it's limited to those who did not follow their pathway correctly. So we didn't get absolutely.
Thank you, Dr. Abtisam. Let us go for the questions. Thank you, Dr. Abtisam. A very interesting presentation and congratulations. What the process are being put in place for the hospital training? Will the lectures be shadowing the students?
The plan is we're going to use our staff that we have already, the specialists that we have. We have 2 specialists and 1 lecturer. And also we already contact, but not an official agreement because the course didn't started yet. So we contact few of the hospitals that has a graduate or midwives from had a postgraduate diploma to establish the training there, and they were welcoming. And also we have the other way, which is contracting with anyone who interested in. We have, of course, they have to have a qualification of midwifery and to be registered as a midwife specialist. So we can do a contract with them to train the students in the hospitals that we have contacted previously.
Okay, great. The second question is, any bridging program for who already have diploma in midwifery?
This is our future plan. Unfortunately, King Saud University rules and regulations and policies do not allow to start the bridging program for a bachelor degree unless this bachelor degree it's already started and established. So this is our aim in future, is to have a bridging program, but not now. Of course, we need to start our the bachelor program first, and have a number of students, and then we can start working on the bridging program.
Okay, great. Our third question is, what will the students do in the first year of the program? I think you answered already that they will go for the nursing
common year, yes.
The common year, and after that they will choose. And how many total of years they will have? So 1 year for nursing, and after?
1 year common year, and then 3 years specialized as a midwife. So all the courses will be midwifery. And then the last year is an internship. So a total of 5. Yeah.
Okay, great. Thank you, Dr. Abtisam. Thank you for your time. Thank you for this presentation. And good luck for the new Bachelor of Saudi Midwives.
Thank you so much, Huda, and good luck in your sessions.
Thank you. We will go for the session with Dr. Insaf. So welcome, Dr. Insaf. Dr. Insaf, she is Associate Professor and Vice Dean of Postgraduate Studies and Researches, Maternal and Child Health Nursing Department in College of Nursing in Taiba University. She's from Jordan. So welcome, Dr. Insaf, and thank you for sharing this session of midwifery education in Jordan with us today.
Thank you. First of all, I would like to thank all organizing committee for this conference. My thanks will extend to Dr. Ru'a to give me this opportunity to be here with you to talk about our experience in midwifery education. First of all, I would like to talk something a little bit about my country, Jordan. Jordan is an Arab country located in the Middle East, middle of the Arab world. It's bounded by Saudi Arabia, Iraq, from here, Syria, and Palestine. The country is a major tourist destination and also attractive medical tourism due to its well-developed health sector. About demographic data, Jordan considers small country with population around 10 million. In total of 54% of the people under the age of 15, so it's younger people, and the growth rate 2.4 per year. According to women's health indicators in Jordan, we have maternal mortality ratio around 30 per 10,000. This is according to Jordan in figure 2018. And the majority of causes for death is complication during labor and postnatal. We have also demographic data about infant mortality rate, which is around 30 per 1,000, and children mortality rate, which is under 5 years age, is around 15 per 1,000. The average ratio for midwives to population is around 2 for each 10,000. This indicator was reflected the problem of shortage in midwives related to numbers and qualification. Now I will move to talk about the history of midwifery education in Jordan. Actually, the first midwifery school was founded in our country in 1950. It's a hospital-based program with female students who's under or below 30 years of age, who were primary school graduated, being admitted to this school. On mid of 60, the Jordanian government operated a 6-month training program for dayas, which is in English called traditional birth attendance. Applicants to this program need to be at least 16 years old, and the primary focus of the program was training for assistants at delivery. This program was discontinued that's now, but because of a strong support for professional midwife and hospital delivery, it's estimated, however, that most local communities still have availability of at least one variant, especially in the south region of Jordan. Almost 30 years later, on mid of 80, two public community colleges began offer 3 years diploma in midwifery. In the same time, there is a program for nurse midwife, which is for both basic midwifery or double qualified midwife, which is launched around in the same time, sponsored by Royal Medical Services. This program, adopted from the UK program in that time, college or university graduates from nursing who wish to specialize in midwifery can apply to 1 year program, which around 30 credit hours in addition to passing comprehensive exam. However, diploma program students who have obtained their high school certificate are eligible for enrollment to this program. The two diploma program or the community college is sponsored by Ministry of Health and offer midwifery education and training to most of the practicing midwives in Jordan. Around 110 midwife students graduate from this program every year. Now the word midwife in Jordan, we have a different call. We have Daya, which is mean traditional birth attendance, grandma who watch birth and then train to help with delivery. We have Qabila who's midwife in English, registered midwife graduate from direct entry program, and both basic midwifery, which is called double qualified nurse midwife, nurse who specialize in midwifery. Again, almost 20 years later, in mid of 2000, the first national university-based baccalaureate program midwifery was launched at Jordan University of Science and Technology, just university. Why baccalaureate of midwifery program? Why we are thinking to launch this program? According to the demographic data and health issues in Jordan, changes trend in midwifery education means the baccalaureate degree is the minimal requirement for entry into practice. Also related to shortage of midwifery, recognize midwife as key provider of maternal health care, a response to United Nations Union Development Goal 4 and 5, focusing on reducing maternal and child mortality rate and improve maternal health. That's why this is indication to launch this program. So we start in October 2001 at Jordan University of Science and Technology, which is located in the north of region in the kingdom, held an educational workshop. This brought together maternity educator, nurse midwife, nurse leader from throughout Jordan to discuss the transfer of midwifery education to university sector and to start to be the minimum qualification in this profession is a bachelor's degree. Another workshop was held 2 weeks later to develop a framework for the midwifery curriculum of the degree level course. It was proposed that 4 years midwifery 4 years midwifery program, pre-registration program, which is direct into midwifery, would cover 136 credit hours in total. Students be awarded a bachelor's degree and completion. The workshop participants also developed guidelines for bridging program, which is 2 years study for a midwife who handle diploma degree for current registered midwife to upgrade to bachelor's degree. So in summary, we have 4 pathway to program and number of clinical theory. This table compare between length, number of the clinical credit hour, theoretical credit hour between the 4 pathways. We have a graduate diploma in midwifery, which is a 3 years, 6 semester with 2 summer sessions. Theoretical hours 81, clinical 26, in total 107. Postgraduate diploma for nursing who going to specialize in midwifery. It's 1 year, 11 months with 1 month holiday, 3 semester, 21 theoretical and 9 credit hour clinical, in total of 30 credit hours. Baccalaureate degree of midwifery, which is direct into midwifery, who have higher scientific branch, go to enter this program for 4 years, 9 semesters, in total of theoretical critical hour credit hour 108, clinical hour 28, in total 136. Pre-registration, which is bridging program for midwife who handle diploma degree and going to grading up their qualification to get a bachelor's degree, 2 years, 5 semester, 51 credit hour in theory, 17 in clinical, in total 68 credit hours. And here I showed theoretical credit hour, it's around 16 o'clock or contact hours. Entry criteria for direct into midwifery program, which is in diploma or in baccalaureate degree. The school average of no less than D+. Jordanian high school certificate for its equivalent, which is scientific stream who have mathematics, physics, chemistry, or biology. Female, we don't have male midwife in Jordan. Medical fit checked by medical fit. Academic calendar in Jordan, it starts the first semester run from second half of September to January, which is called in international fall semester. The second semester run from beginning of February to June, which is spring semester. Each semester have 15 weeks of courses followed by examination session, which is covered an additional 3 weeks. The structure of the program, highly integrated and focused program, course completed over 160 weeks in 4 years with 8 weeks annual leave per year, 44 programs with each year. The course was delivered using both clinical and theoretical elements with 60 to 40%. That means 60 credit hour, 40 credit hour theoretical, 40 clinical, weighting respectively. First year shared learning with nursing program. Usually, first year students who going to take qualification in nursing, studying with students who are going to qualify in midwife in first year, sharing a program in general courses. Every year focus on content, while later years covered by practical. So we don't have practical part in first semester in first year. The practical part starts in second semester. Content is structured from simple to complex, health before illness and normal before abnormal. Also, there is a requirement for each program to have a general courses, which is university fundamental requirement, talking about computer, English language, Arabic language, which is around in diploma 12 credit hour, however in baccalaureate 22 credit hour. Also, we have supportive requirement courses, which is talking about anatomy, physiology. This is around 80 credit hour in diploma, however 32 in baccalaureate degree. Faculty specialized requirement, which is specialized courses related to midwifery, it's around 77 in diploma, however 82 in baccalaureate degree. So in total, we have 107 credit hours in total for diploma, 136 credit hours in total for baccalaureate degree. Clinical placement starts only, as I mentioned, during the second semester of the first year. Students are always required to complete a comprehensive clinical placement during the final semester for each 3 years. The first semester from the first year of the program concentrate in 4 courses required by university for all students and by the faculty medicine. During this first semester, students also attend the clinical laboratory session where they are taught basic skills in preparation for clinical placements in their second semester. The medium of instruction in Jordan is English, so all interns have a fair command of spoken and written English language. Clinical placement, it's coming in different modes. We have weekly and a block 2 months or combination. The following area where students maybe gain experience, which is we have 60 weeks in labor and care, 16 weeks in community health centers, 16 weeks in pediatric and NICO. However, the antenatal period is distributed between gynecology ward, which will take 6 weeks, and antenatal ward, which takes 10 weeks, and we have postnatal ward for 16 weeks. The minimum clinical practice required to gain the word, the students at the end of the program must have experience like 60 to do 60 prenatal examination, supervision and care for at least 40 women in labor, carry out at least 40 deliveries, and assist in 15 cesarean or instrumental delivery, which is high risk, supervision and care of 40 women at risk in pregnancy or labor or postnatal period, supervision and care including examination of at least 60 postnatal women and healthy newborn infants, perform the teaching session, family or exercise, 10 breastfeeding support visit, 15 postpartum visit in early postpartum period, and 15 also same on late, which is around 4 to 8 weeks post-late. In addition to that, there is a comprehensive clinical exam. Competencies describe the nature and characteristic of the person who uses the title of midwife. The association or the council who is responsible for accreditation, we have Jordanian Nursing and Midwifery Association, published who is responsible for accreditation, published and articulate standards, attribute the capability that those of midwifery qualifications should be able to demonstrate. The structure of these competencies contain 4 domains. Where the first domain about providing health care, all health care related to a profession. The other domain, the second domain about administration leadership. The third domain about education, training, giving instruction for health education, and the fourth domain about research. So the aim of the course to be safe, competent, confident, compassionate practitioner, accountable and autonomous, lifelong learning skills, evidence-based research, and family-centered approach. After all this experience, which I'm talking about with all this journey from 1950 to 2005, and now we are 2010, 20, we have a lot of challenges, which is, I think, it's sharing with Saudi Arabia and other Arab countries about this experience, because we're still struggling with something around the midwifery education in Jordan. I can summarize these issues by the first year of program has the greatest input from non-midwifery teaching because we don't have enough qualified teachers specialized in midwifery and have experience in clinical area. Nursing students are put together. Thus, when students are mostly beginner, there is a lot of input from non-midwife or reflection in illness rather than in wellness. Also, absence of birth center. We don't have in Jordan birth center or delivery at home delivery. In addition to increases of technology in hospital, it doesn't still we are struggling with evidence-based practice and normalization of childbirth. Limited the opportunity for students to learn about normal childbirth. The staff to student ratio also is an issue, which equal 1:6 in labor room and 1:10 in rest of maternity department, affect the level of supervision and support availability of the students during the clinical training. All these issues is related to the cancellation of higher midwifery education 30 years ago, left a debt of a qualified midwife teacher, administrator, leader, and role model, weakened the infrastructure. Even as a program were expanding with the limited educational opportunity for midwives, the lack of an infrastructure for master and doctoral degree. We don't have still in Jordan master or doctoral degree in midwifery. All these limited the further advance of midwifery profession in Jordan. The staff who took on the role of midwifery educator must have experience in clinical instruction and the current knowledge to address the gap between theory and practice. And this is another issue which is facing because all the teaching staff in uni who's get scholarship to study in UK, Australia, America, and then back immediately to teach without having any experience in clinical area. What lessons we can learn from this journey? Lessons to be learned. Designing direct entry midwifery curriculum need to be considered carefully within a collaborative effort across the country. If each university were to try to establish direct entry midwifery program in isolation, you don't cover the shortage of the area for clinical training, shortage in staff and teaching faculty members. This could have serious consequences for midwifery related to the scarcity of the resources, clinical training, availability of expertise. So Saudi University need to move together toward developing midwifery curriculum that merge the uniqueness of the Middle East philosophy with elements of Western models to get normalization for childbirth to cover all requirements according to ICM. This is lesson can be passed at the end of my presentation. This is my references. We have just all these published paper around midwifery education in Jordan. Thank you for all.
Okay, hi Huda.
Thank you for sharing this nice presentation about the Jordanian midwifery program. And I want to ask you what we can learn from your experience from Jordan, or what's the most important strong part in your program and in your midwifery system?
Thank you, Huda, for your question. How are you for all? I am happy to be with you now. According to your question, we have a positive point and negative point, or everything have disadvantage and advantage. The positive thing is that we have a qualification requirement. Before you are graduated from the program, you need to cover minimum numbers of delivery, examination, teaching session, all of these that, as I mentioned in my presentation. And the other thing is strong. It's the first program launched in Middle East country. I think we don't have in all around the boundaries of my country, any country have a baccalaureate degree. It's good to hear that Saudi Arabia will start next year in bachelor degree.
I think also Lebanon, they have Bachelor of Midwives, Palestine. In few countries, there is Bachelor of Midwives.
Lebanon, it's not in our boundaries. It's with Palestine. Okay.
Okay.
Okay. The disadvantage or something we need to be strict about it. That's I mentioned in what lesson can be learned. If every university going to launch a separate program, there's a problem with the faculty member because I mentioned 30 years ago we don't have baccalaureate degree, we don't have master, we don't have PhD. In the last 10 years, the university start to send for scholarship to get specialty in midwifery, but this staff retained back and get the position in education immediately before getting practice in a clinical area. This is making a gap between theory and practice. The other thing, when you are going to teach your student about the update about the ICM criteria, the normalized childbirth, evidence-based practice, it doesn't the case in the hospital or in a clinical area. The hospital clinical area is still working in medicalized model. So there is a confused area between to find a suitable area for training to your students. Other thing, the student faculty ratio. We have a scarcity in faculty member, so maybe 10 to 15 students with one teacher. This is decrease the time for supervision and to be contact for support. I hope I answer your question.
Yeah, thank you very much, Dr. Insaf. Another question is, thank you, that it's very informative. Why do you think they stopped the higher education of midwifery 30 years ago? And how do you think it can be restarted?
It's not stopped. It's not start. Even it's launched not launched at all in Jordan. We don't have. This is the first time we have experience to launch a direct entry midwifery program, and we cannot open master program or doctoral program if you don't have baccalaureate in your country. You need to have bachelor's degree in your country. Yeah, start before starting master or doctoral degree. So after we launched 2 graduation or 2 generation or maybe 3 generation from bachelor's degree, we can start to think about master degree.
Master and PhD.
Yeah.
Thank you, Dr. Insaf. Thank you for timing, and thank you for sharing the Jordanian experience. And inshallah, for the future, you will have a master and PhD in midwifery, and we're starting with this bachelor. Thank you very much.
Thank you. Thanks.
We will go for the next session. Next session is VBAC, or vaginal VBAC with Dr. Fatma Shangiti. Dr. Fatma Shangiti is currently employed at Elite Hospital Riyadh as a consultant OB-GYN. She's a female pelvic reconstructive and minimally invasive gynecologist surgery. She's also working in the Ministry of Health, Riyadh, as a supervisor of obstetric and gynecology service development. She's moreover, she's severe as the main employee and the Gadage Medical Care Hospital. So thank you, Dr. Fatma Shangiti, to sharing this lecture for the trial of vaginal delivery after cesarean section. Thank you.
Hi, this is Dr. Fatma Shangiti. I'm going to talk about vaginal birth after cesarean section. Mainly, it's about my experience in Saudi Arabia in the last 2 years. So when we look worldwide about the cesarean section, we can see that it's an epidemic, and this paper the cut above and the cut below in Brazil, talking about that the maternity hospital and they have either to do an episiotomy or actually to have a cesarean section in order to deliver the woman. And they were discussing a lot of issue about the maternity care and also the women abused during vaginal birth. And if we look into the country that conduct the most cesarean section, you can find that it's in Dominican Republic and Brazil are the highest rate, 55.5, and Egypt actually in the Arab world is like the highest rate of cesarean section. So you can see like it's rising up rather than going down worldwide. 1 in every 5 women in the world now give birth by cesarean section, and the rising primary cesarean section, it's a significant contributor. So this is why when I reviewed the literature in 2016, I decided that we have to do something in Saudi Arabia, and to increase the awareness of the women and the family about the cesarean section and its impact, because also it contributes to the maternal mortality in Saudi Arabia, which is around 17 in 100,000. And 50% of these cases actually in maternal mortality are either during cesarean section or post-cesarean section in Saudi Arabia. So what I did, I reviewed the literature and I did a lot of infographic where in Arabic in order to launch it. And we chosen the month of April, which is known worldwide is the cesarean section month. And we are doing this every year since 2017. By releasing the infographic about information, cesarean section, cephalopelvic disproportion, about the breech, about all the things that related to cesarean section in order to increase the awareness in Saudi Arabia and even in the Gulf area or the people who can access to my Twitter. So we did also an agreement with the Saudi Society of Obstetrics and Gynecology and Rufaida, who also they launched these infographic also in their website. And if you can see what is the most common medical indication, it's the previous cesarean section. And as we said, the most contributor for cesarean section in the world is the primary cesarean section. This is why in 2014, the American College of Obstetrics and Gynecology, they released their consensus regarding the safe prevention of primary cesarean section. Because if we prevent the primary cesarean section, it means that we prevent 50% of the current cesarean section rate. The other categories are either advanced maternal age, nulliparity, or fetal distress or other categories. So we are trying to concentrate on the primary prevention, on the prevention of the primary cesarean section, even here in Saudi Arabia. And if you look at why the obstetrician doing cesarean section, either because of the convenience incentive, the lack of supervision and training in the hospital, and the lack even of following what's going on in the hospital as their outcome and their statistic or even clinical audit in these hospitals. Absence of and lack of knowing the clinical guidelines, or even what they think, what's in their mind that they think that they have to do cesarean section. So whatever their practice is going on, they keep continue even with the presence of the clinical guidelines. Some papers, like in the Brazilian paper, they said they either were short in bed, workload, or the physician at midnight, they would like to sleep, or during the weekend because they are tired. And in some country, they think it's because of the increased medical legal and no coverage, good malpractice, and people going to court a lot because of the hypoxic ischemic encephalopathy and the outcome. So they found the easy way is to go cesarean section. And even when women go to the physician to have a vaginal birth after cesarean section, to give her the trial is very difficult to convince them. And even if they're going to give the trial, they give it for a short period of time, and then they decide to take the woman for cesarean section. If we look at the national guidelines from several countries across the world, including Royal College, American College, all of them, they were stating that it's acceptable and a clinically safe choice for the majority of women to attempt vaginal birth of cesarean section after one previous cesarean in an otherwise uncomplicated pregnancy. So even though that American College and the Royal College and most of the guidelines releasing encouragement of vaginal birth after cesarean section, they release the prevention of cesarean section. Still, we are having people saying once a cesarean, always a cesarean. And even though this is a long said, but people still doing it. And it used to be in 1995 until 2004, the rate of vaginal birth after cesarean section is around 40%. But however, after that, vaginal birth after cesarean section start to decline and people going through high rate of cesarean section. However, we have to know that there are two standard pathways. So when women come to the clinic, you have to give her two options. Either you have to offer her elective repeat cesarean section according to the choice that she wants, if she has a previous one or previous two, or you offer her vaginal birth after cesarean section, and you have to tell her that 70 to 75% will have a successful vaginal birth. And you continue counseling her and discuss with her the relative risk versus the benefit through antenatal and even during the intrapartum period, and encourage her actually to go to vaginal birth after cesarean section, especially that all of us, we know the complications and the future. And also we shouldn't forget that in our culture in Saudi Arabia, people tend to have big family. So we have to put that in our mind. We're not like a culture that have 1 or 2 kids only. We are a culture of having 4 or 6 kids, sometimes 8 kids. So we have to put in our mind that with repeated cesarean section, there is a chance of having more kids is going low, and this has to be very clear for every woman. What I found in my clinic that people come when they have cesarean section, always worried about, I have pain in my scar, I have abdominal pain, I think my scar is going to rupture, I'm worried about my scar. So abdominal pain is a main reason, and uterine rupture is something people really worried about. So if we look at the definition of uterine scar rupture, there are 2 definitions, either full thickness or dehiscence. So if we said about full thickness, then we're talking about the whole uterine layers, including the serosa overlying the peritoneum. And when this happens, usually it's associated with fetal distress, maybe, and the patient has to go for emergency cesarean section, may end with bleeding or hysterectomy and uterine repair. It depends exactly what happened during the cesarean section. But however, if we have only uterine scar dehiscence, which is a small tear or separation of the pre-existing uterine scar, this is more commonly that happens if it's going to happen, but rarely result in any major fetal and maternal complications. So what women actually fear, thinking that she's going to end by rupture, this is rare event. And if it's something going to happen, most likely it's going to be uterine scar dehiscence. And if we look here into the layers, so just to make it easy, when we do cesarean section, we go through 7 layers in the abdomen, including the skin, the fat, the peritoneum, and the muscle, and then the uterus. So this is when we are talking about the uterine rupture, it means only the uterus and the peritoneum, which is like the layer above the uterus. And when we're talking about, so it has to open all completely. And even sometimes the placenta come out, even, or the baby has to come out. But when we're talking about dehiscence, so it's only this area that's gonna open, but the rest actually is intact, and the baby actually is inside the uterus as not coming out. So the uterine rupture in labor has a certain percentage if it's according to what was actually the previous scar. So when women come in the clinic, we have to ask her what was her scar in the uterus before. So if it's a classical or T-shaped cesarean section, this is her risk of rupture, 4 to 9%. If it's a low transverse cesarean section, it's 0.4 to 0.7%. If it's a low vertical uterine incision, 1 to 2%. And what we said, inverted T or J incision, like 1 to 0.9 rupture risk. But most of the patient actually, they have low transverse uterine incision, so it's 0.4 to 0.7%. Rarely we'll find a patient who had a classical or low vertical or any inverted T. But this is why it's very important to ask the patient, what did happen in the last cesarean section? Did they tell you anything about your future pregnancy or future delivery? Do you have an operative report? Just to make sure that when we see her in the clinic, that we are actually collecting all of the data. And what are the factors that actually you have to put in your mind that can increase the risk of rupture? If she has a previous uterine rupture, if she has a previous fundal or vertical hysterotomy, which means it's an opening of the fundus of the uterus, or if she you gave her induction of labor with the prostaglandin, that may prone her to and increase her risk of uterine rupture. So again, we go back to our work with the patient in Saudi Arabia. So now when I have a patient in my clinic, and I started talking about and releasing infographic in 2018 about women with the previous 2 cesarean section, they can go into vaginal birth. So women with 2 previous cesarean section, you can see here now Royal College, American College, because of the epidemic is rising really high, and women losing her chance after 1 previous cesarean section, and she goes for her second, and again the woman actually they experience their complication or the pain, or they saw their experience is bad in their cesarean section, and they want to have their chance again for another trial after 2 cesarean section. They were actually rejected. So this is why I started to give the hope for the woman in Saudi Arabia by releasing these educational infographic about previous 2 cesarean section. So if we look at the data, we find that with the National Institute of Child Health and Human Development showed that there is no significant difference in the rate of uterine rupture if you do it with 1 cesarean or previous 1 or previous 2 cesarean. They are the same risk of rupture. Even the Royal College of UK, they are actually encouraging to give the trial of vaginal birth after cesarean section with certain requirement. And you can tell the woman that the success rate of cesarean section after 2 cesarean is around 71.1%. So when they come to my clinic, I counsel them about all of that. However, when I review the literature, I saw that the only point that different between vaginal birth 1 and 2, that the rate of hysterectomy and the blood transfusion is more with the previous 2 cesarean section. However, the rest of other complications are the same. So since we are talking about hysterectomy, blood transfusion, I start to review the literature, and I found that, and I see what's going on in Saudi Arabia. We find a lot of anemia in Saudi Arabia, iron deficiency anemia. So I started to do the preventive way of any patient who's coming with us for any trial, either 1 or 2. So what are actually the contraindication to vaginal birth after cesarean section? I have to make sure when she comes to the clinic that she doesn't have a previous uterine rupture, she doesn't have a classical cesarean section, and she doesn't have any absolute contraindication for vaginal birth like a placenta previa. And if she tells me I have a myomectomy, I have a surgery before, I still give her a hope, and I follow her, and I take my decision at the end of the pregnancy by looking at the scar. And so I decided accordingly to certain criteria. So this is why even in the Royal College of Obstetric and Gynae, they said it has to be case by case. The decision has to be taken by senior obstetrician and with the access of the previous surgery in order to decide, shall we give her attempt of VBAC or no? And what are actually the things that actually lead to successful VBAC? When I take the history, if she has a previous vaginal delivery, then I know that this is a good chance of her going into a successful VBAC, or a previous successful VBAC, or she has a lower transverse cesarean section, she has a good adequate pelvis, no any abnormality in her uterus or previous rupture uterus, or if she actually, when we reach to 40 weeks, she has going by herself into labor, or she presented with rupture of membrane and contraction and actually with good Big-Chip score. And I think really the main determinant factor for successful VBAC is the relationship between the patient and our pregnant woman and her physician, and her willing and her psychological status, and that she is going to and what does she think about she's going into through this experience. If she's really persisting and she would like to do it and following all my requirements as I explained to her, then this is part of the success of her vaginal birth. So really you have to go into the patient thoughts and speak with her and discuss with her every time and make sure that this is what she is really willing to go in a supportive way, not as terrorizing from the experience. Also, we have to make sure that when we are in the hospital that we have a blood bank, anesthesia ready for any emergency, and also the hospital is ready for monitoring this pregnancy. So if we look into also the American College, they have vaginal birth after cesarean section, and they look about what are the stuff that actually can decrease the probability of the success. Not because if we're seeing this, we think, oh, you're not going to succeed. No, we have to give her the trial of vaginal birth regardless of the factors. The only thing that can make us hesitant if she get a big baby, putting into mind that ultrasound at the after 39 or 40 weeks is plus minus 200 to 300 or maybe even to 500 gram different, depending on the machine and what is the quality of the machine and subjective to the people who's measuring it. So that's something that we have to put into the mind, that the fetal weight is important at the end of the pregnancy, but it has to be like something we're talking about 4 kilos and above, not something like 3 kilos or 3.6 or 7, because all of these are acceptable weight, but 4 kilo and above, we have to think about it. So this are the things that American College, they put into their thing that these could actually decrease the success. So when I go through all of this with the patient, when she comes to the clinic, I have to tell her that we have to follow the Ministry of Health guidelines. And as you can see here, the new book of the Mother Health Passport, they put that in every woman that we have to do in they change their antenatal care, and now they put the CBC and they put the ferritin, serum ferritin. And the serum ferritin in pregnant women has to be above 100 in order to make sure that she doesn't have iron deficiency anemia, and also the hemoglobin has to be above 12. So I will not take any patient below that, even at the end of the pregnancy. So in the Mother Health Passport, they do the CBC and ferritin 3 times during pregnancy, at booking, at 24 to 28 weeks, and then again between 32 and 34 weeks, to make sure actually they are at expected level to decrease the iron deficiency anemia and the postpartum hemorrhage. So I go with the patient also in the clinic, discuss the informed consent of trial of labor, and I have also in Arabic and in English, and I explain about the benefit of the natural birth after cesarean section, to encourage her to take the trial, especially that the pain is less, she's moving, she's recovering quickly, and really I go through this to convince her to go for vaginal birth. And also I have to mention about the first week after childbirth complication with cesarean section that people think they don't know it, like thromboembolism, risk of placental anomalies, and all of these complications. If we did cesarean section, I have to discuss it with them. So these are the complications in the first 6 weeks after childbirth if we do cesarean section. So I have to explain what is cesarean section, how we do it, what's the technique, what are the complications if we do elective cesarean section, and what are the complications of one cesarean section or two cesarean section. And so not to forget, neonatal outcome is very important. And as you can see here, respiratory morbidity, transient tachypnea, hyperbilirubinemia actually is more with elective cesarean section and less with the trial of birth after cesarean section. So I really encourage them for seeing these points of the benefits of vaginal birth after cesarean section. So these are the stuff that in my clinic I do. This is my practice. The CBC and ferritin, as I mentioned. Number two, I have to make sure that they are not diabetic. I really concentrated in my practice on the glycosylated hemoglobin, fasting blood sugar, and I insisted on OGTT. If they refuse, I tell them to do at least 1 week readings for me of blood sugar to make sure they are not diabetic. Also, I use a really strict criteria for 2 hours reading in the house. Vitamin D3 and B12, I noted that it is low level in Saudi Arabia. So I do it for my patient, and I make sure I treat them and they are at acceptable level by 32 to 34 weeks before delivery. Ultrasounded early pregnancy for the scar, just to make sure there is no complication from the previous cesarean section. At 34 weeks, I do also uterine scar measurement, thickness, and fetal weight again, just to see that did we miss any diabetic patient or not, because also if I see big size baby by 34 weeks, then that's an alarming for me that maybe she's eating a lot of sugar, because we have some practice in Saudi Arabia. People think eating dates can make you to go into labor. However, eating dates it's a wrong practice. They shouldn't eat dates during pregnancy, except for 1 or 2 pieces. But what people did here, they eat a lot of dates, and they think labor gonna start if they're gonna do that. But actually, they are harming their baby by increasing the sugar and increasing their weight and ending by complication. So the dates only when they are actually in labor on that day, not during pregnancy. Also, I do the group B streptococci for them. So when they rupture their membrane and they are not having contraction, I have a peace of mind that they can stay into their house for 18 hours until they are actually going into by themselves in labor. So I don't do an interference if they are GBS negative. And also urine analysis, I check them 4 times during pregnancy to make sure we're not dealing with diabetes or proteinuria or an infection. So these are the most stuff necessary for me, plus of course the antenatal screening. Also, if we look into the effect of antenatal pelvic muscle exercise, I really look into this, and I stressed on the woman that they have to do this, because antenatal pelvic floor muscle exercise during pregnancy has proven to be effective in shortening the second stage of labor and reduce the severe perineal trauma. So these are the physiological changes during pregnancy, that with the relaxation, with the hormones, these muscles actually gonna become weak, they're gonna separate. And also if she has previous 1 or 2 cesarean section, most likely they are really weak and they are separated and they may have a deficit. So I really ask them to go and start core, body, and pelvic floor exercise. And I have to make sure that they understand that when they do the breathing, that when they are taking a deep breath in and they are actually inhaling, what is the effect on that on their pelvic floor, and when they are exhaling, that they are relaxing their muscle. However, during the exhale, if they would like to do the Kegel exercise or the pelvic muscle, they have to do it during the exhale, not the inhale, because most of the people, they are actually doing the reverse. They are taking deep breath and they are contracting their muscle, causing a more damage. However, they should be taking a deep breath, and while they are releasing their breath and exhaling it, they should contract their pelvic floor and abdominal muscle. So they have, I refer them to a woman pelvic floor rehabilitation, where actually she check their abdominal muscle and she work with them on the core, body muscle, and pelvic floor exercise. Placenta localization, these are the questions that I ask, many people ask me about it. And I thought maybe I'll just mention it quickly here while everybody can listen, like especially the midwife. 4% of the pregnancy are identified by low-lying placenta by 18 to 20 weeks. And I receive a lot of questions, my placenta is low-lying. Nobody cares about the placenta at 18 to 20 weeks. What is important is the placenta at 32 to 34 weeks. Because 4% actually they can have low-lying placenta. What do I care about previous one or previous two? Where is the placenta? So the risk of placenta previa of invasion in the first cesarean is 3%. In the second cesarean is 11%. In the third cesarean section, 40% she can have the risk of abnormal placenta and invasive placenta. In the fifth cesarean section, she can end by 67% of placenta accreta or increta. So the more cesarean section she do, the more abnormal placentation and the more the risk of placenta accreta or increta. This is why it's very important that you do the scan at the early pregnancy, you do scan again in the middle pregnancy to see where is the placenta, is it anterior, is it on the scar, near the scar, what is the relationship with the placenta. So by 32 to 34 weeks, if the placenta previa is diagnosed anteriorly, so what we have to look is the placenta anterior or posterior, number one. Number two, where is the relationship of the placenta to the scar? So at 32 to 34, if it's really still anterior and low, then you have to send the patient to do an MRI. And if it's really proven, then you can plan her for cesarean section. But as long as the placenta is 2 centimeters away from the internal os, she can go for a vaginal birth if it's a posterior placenta. But if it's anterior placenta, make sure where it's exactly, what's the relationship between the placenta and the scar, and make sure to rule out with the Doppler, with the MRI, any invasion of the placenta to the uterine wall or to the bladder. Can we predict uterine rupture? Because the patient can tell, oh, doctor, am I going to rupture? I don't know if she's going to rupture or not. Nobody even can tell her. Nothing even by ultrasound or anything can rupture, can predict rupture. So it's only she has to go into the trial, and we can pray that day everything that's going to go well. And that's the only thing we have. But nobody actually, and nothing actually scientifically until now that can predict, yes, if you go 100% you will rupture. It's all by chances, and maybe she will be we will terrify her for nothing, but she has to go into her trial. So when we measure the lower uterine segment scar that I mentioned at 30 at the beginning, I measure it early pregnancy, then I measure it at the 32 to 34 weeks and late pregnancy. If it's 2 millimeter and above, this is a very strong negative predictive value for uterine defect and predicted a higher chance of successful VBAC. However, 0.6 to 2 millimeter, maybe they have a strong positive predictive value for uterine rupture. So I still tell them that they may rupture, but I don't terrify them, and it's her choice. If she would like to try with me with a close monitor, then we will do. Put into mind, you see, if it's below 12 millimeter, 4.8% rupture. If it's 13 to 20 I'm sorry. This is the interval with the. This is the interval with months. I'm sorry. This is again another question that people ask me, Doctora. I had my cesarean section less than 1 year. I have my cesarean section less than 6 months. Are you gonna give me trial or not? So I counsel them about the rate of rupture. So if it's below 12 months, then it's 4.8% rupture risk, and if it's between 13 to 24, the risk is 2.7. 25 to 36 months, 0.9 rupture, and more than 36 months, it's 0.9 rupture. So the risk is really only if it's 1 year. So always I ask the woman, try to at least stay 1 year without getting pregnant. But if they get pregnant before 1 year and she really would like to try, I have to do really close monitoring with her and I give her the trial. But I don't like to take the chances, but if she's insisting, I will help her. But as you can see here, below 1 year, it's really high risk of rupture. Then trial of labor after cesarean section, the facility has to be really good. Anesthetist has to be present, as we mentioned, blood bank, you have a backup, you have nurses, midwives, supportive care, that actually if anything happens, you are ready. Do I do induction or augmentation? What are the recommendations for induction if she passed post date? To go with the balloon, not with the medication. If it's one cesarean section, some people, they give prostaglandin half a dose. It's still recommended. It's not something contraindicated, but with the half a dose. Misoprostol is contraindicated according to the American College of Obstetric Gynecology. But like I do after 40 weeks, if she doesn't go into labor, I do some sweeping of the membrane. I ask her to try the blueberry tea and also the pineapple, these stuff that it can may softening her cervix. And if she reached to 41 week, again, I try to do the sweeping and hoping that she will go by herself into labor. But there is a chance, but previous to cesarean section until now, there is no any study to encourage doing induction of them. So usually I stay with them as much as we can to 42 weeks to go by them naturally, especially by 2 cesarean section. 1, we can do induction by half of the dose of prostaglandin, but 2 cesarean section, until now, I have to wait for them until they go by themselves spontaneously. If they rupture their membrane, can we use oxytocin? Yes, we can use oxytocin in both previous 1 or previous 2. The risk of uterine rupture with the oxytocin is like 18 per 1,000 in oxytocin use and 25 patients per 1,000 if prostaglandin. So when you have to when you counsel the patient, you have to tell her the risk of rupture actually increasing when we are using medications rather than it's a spontaneous. So when I admit the patient in labor, I have to put her under monitor, mobilizing, she drink fluid, encourage her to give diet, fluid diet like soup and everything, soup. And I have to look into the clinical sign of uterine rupture, like abnormal fetal heart, vaginal bleeding, sudden worsening of abdominal pain, or we gave her like epidural and she's still requesting more epidural. The head was like 0 or +1 and suddenly I cannot find the head, or she became hemodynamically stable or hematuria. The most actually, like until now, the most currently available and recommended and has a good prediction is the CTG, even though that we know the CTG has 50% false positive, false negative, but until now CTG, fetal tachycardia, reduced variability, especially reduced variability, that actually associated with decelerations that can increase actually your thinking about it could be something going on. Early deceleration, I don't act on it, but if there's any time repeated deceleration, the pathological CTG, then I have to stop the trial. When the patient delivered, do I actually go and put my hand in the uterus to check? No, there is no necessity to actually do uterine exploration at the time of birth to evaluate the uterine rupture. If there's no any abdominal pain after her delivery, there is no vaginal bleeding, everything is going well, I don't even put my finger, I just do uterine massage, clean her. If she has any tear, then I suture the patient. And I'm going to share with you my data. We have 30 deliveries of vaginal birth after 2 cesarean section in the last 2 years, but actually I could only manage to collect 25. The rest, the other 5, I did not actually yet find a time to collect them. As you can see, this is the range of their age from to 25. Can you imagine? We have a patient 25 years old, we have 2 cesarean section. Most of these patients actually, only one of them had previous 1 vaginal birth. The 24 patient, all of them actually, they never had any trial of vaginal birth before. And as you can see, this is the tear that we have with them. One of them actually had failure of vaginal birth of cesarean section, maybe because of the weight of the baby, 3.8, but she reached to the 2nd stage of labor, and it was a prolonged 2nd stage of labor. So we gave her full chance, SIN2 and everything, but did not progress. So we took her for cesarean section. Was there any maternal complication? None. Was there any neonatal complication? One only, that was admitted to the NICU because of meconium aspiration. That patient had a thick meconium, but also I still have some other patient here that have a meconium that they did not actually end by admission to NICU. But as you can see, most of the baby actually, they are doing fine and successful birth. So I'm just sharing with you my good news that until today, I have 30 patients with vaginal birth after cesarean section, and alhamdulillah, all of them with a good outcome until now. So in conclusion, management of pregnant women with 1 or more cesarean section, they are the same. You have to make sure that you encourage them to follow up pregnancy with the stuff that I mentioned necessarily. They have to take care of their core muscle, abdominal muscle, and pelvic floor. You have to rule out any medical or surgical contraindication. You have to counsel them very well. Informed consent is must. I have to really talk about the doula here and the antenatal classes. Any patient who's going into vaginal birth after 1 or 2 cesarean section, it's a mandatory in order for them that I accept their cases that they have to take antenatal classes, they have to do their exercise, and doula is must present, or a companion who's acting as a doula is must present, because I think most of the patients who ended by a failure of vaginal birth after cesarean section because of no support, or because of the threatening environment, or because they don't have really the environment that encouraged them. So the doula is must in every vaginal birth after 1 or 2 cesarean section in my room with the patient, in order to support her, to do with her the breathing, the movement in the room, to give her the shower, the warm compresses during birth, to support her back, to give her a warm, to give her the massage, and all of the things that to really decrease the pain and to encourage her, and even to make her, to give her the positive experience during birth. We talk about the counseling, review her record, discussed the informed consent, and also at the end, it's her choice if she want to do that or not for vaginal birth. During admission, you have to monitor her, give her analgesia, supportive doula, and supportive care. When you see any sign of uterine rupture, you have to counsel her again and take her for cesarean section if you think really she is having a risk. And caution, if you're going to do any induction or augmentation, I just want to mention about Synto. I do syntocinin augmentation. But I don't go really high. Usually my protocol is to put 5 units of Synto in 500 ml of normal saline, and then run it at 6 ml per hour and increase it every 30 minutes. I've never reached more than 18 ml per hour because my aim is just to give her a small amount of Synto just to stimulate the uterus, because sometimes they are exhausted. And mashallah, until now I ended by a very good outcome, and alhamdulillah, all of them, they are happy, and they with their experience and even with their attempt. Thank you for listening, and I hope you learned something from my lecture. Thank you.
Thank you, Dr. Fatma, for this nice presentation, and especially it took I'm happy that you have like a rate of 30 successful vaginal delivery after cesarean section. Actually, it's not common practice, and as you mentioned, for sure, with restrict case by case, and it's not common for all patients that she has already previous to. And thank you for this opportunity, and you take a very nice look for these categories of mothers that she really need to take her trial, of course, with all the benefit for mother and baby. So we can go for the next session. It will be with Ms. Fatma Ali Murad Al-Blushi from Oman. She's head of a midwifery program, the postgraduate diploma and basic scientific in midwifery in the High Institute of Health Science of Ministry of Health. Thank you very much, Ms. Fatma, to join us for this conference and to be part of our day with lecture, midwifery, and life challenges.
Hi, everybody. This is Fatma Al-Blushi. I'm from Sultanate of Oman. I work as a head of midwifery program for postgraduate studies and Bachelor of Midwifery, Bachelor program of Midwifery. And today we will be just talking about or discussing and about the challenges that face midwifery in the current year. And definitely there are many challenges. However, I try to just choose few of them to concentrate on, because I feel that those areas are, to certain extent, are important to be considered by midwife and their profession. So this presentation actually is very short, not that too long. Just I will be coming across the main life challenges that affect midwifery, and we will go also to see how midwifery was doing during the pandemic, and how can we help for the future. Well, the world is facing health crisis unlike any in the past history. COVID-19's outbreak is much more than a health crisis. It is a human, economic, and social crisis. It affects all the segments of populations, affects societies at their core. The measures to control the spread of the virus have reached deep in our lives, affecting people's income, job security, and social contacts. Globally, the public health workforce and local governments actually they reshaped their work in an effort to contain the infections and protect the most vulnerable people. It is obvious that the care of childbearing women during this remarkable period of history also affected and moved to another phase with challenges. And it is very early to identify its real impact, especially in the absence of appropriate vaccine, as well as the continuation in the technology advancement and getting something to solve the issues that we are facing. Yes, we can say that economic are timidly reopening, but they do so while keeping an eye on the epidemiologic evolutions to shape accordingly. And even though the future is still unknown, one thing is sure, as people adjust to this new normal, where the most ordinary activities, our lives, all types of jobs, including midwifery, move to the online sphere and technology adaptations. Therefore, maybe my concern in this presentation will be about the technology and how we are using that in our midwifery and the profession where mainly we are talking about normal and normality. We are talking about the touch, about the humanity, about feelings, about psychology. So how this technology is going to be a part of our profession. As you can see that technology has invaded our life, did not leave any member of the family without being affected. The old and small, even you can see that they are and somehow are affected by the technology. So are we really moving toward technology? This is the questions that we might be having an answer for it by the end of this conversations, or we need to put it in our mind so we'll be able to prepare ourselves for the future. What are the main challenges in midwifery care during the pandemic? Did the midwives face any changes in their role while they were working during the pandemic? The answer is yes. As others, they have made some changes just to maintain the social distance and reduce the cross infections. What they did actually around the world, they reduced the number of antenatal visits, whether for normal or complex or medical conditions. They reduced face-to-face care for all ANC mothers. And they shifted to online or telephone consultations. They advise mothers to do the self-test and measures, especially for those who are having some medical conditions or deviations. The number of cesareans or planned cesareans had increased from the fear of being infected if they will go for the normal birth. And some of them, maybe most of the people have put a plan for the home birth where it was not in mind in a couple of years or in their previous deliveries. They reduce postnatal face-to-face care provision, skin-to-skin and breast feeding promotions for affected mothers. So briefly, we can see that they have really moved to a different way of caring for childbearing mothers. Well, when we are talking about these challenges and how it really affects the entire world, we can imagine that these challenges or this pandemic will not affect only on the type or the flow of the work. It will have some economic. We will be having some economic disasters because spending money and treating people, trying to get solutions is all costing money. With the precautions measures that has been followed by countries, definitely we are going to struggle for the coming years. According to the World Bank Group, they expect that For the year alone, for this year alone, the global economy is expected to shrink by 5.2%, the worst recessions since 1998. So if it is going to be the worst, so what we were having before 2020, so we have to think seriously that what we are going to face in the coming year is not going to be easy. So we have to put a real and a very careful plan. Extreme poverty will rise for the first time in a generation by about 10 million people worldwide. The number of people who face food insecurity is also forecast to double in 2020. So from all the above, we have an impact in achieving the sustainable development goal. And we know to which extent midwives were really contributing to these, to achieve the sustainable development goal. And in this way, it means that we are going to really have problems in the coming years. In general, the COVID-19 pandemic has led to a dramatic loss of human life worldwide and presents a remarkable challenges in the life. And it affects also, mainly I have chosen these three areas, the public health. So when we talk about the public health, women and babies and families are part of this public. And when we said that the care was moved toward the technology, it is obvious that we will be using the technology more than human. So there will be a chance of automations and use of robotics in the care provided. And there will be a great use of the artificial intelligence and machine learning. Yes, there were in previous years we were using, but the use of it might increase because of the current situations. So what's happened to the public health? Most countries moved to expand their health workforce as the COVID-19 pandemic developed. And the common responses they did, just they were inviting recently retired staff back into general medical practice, which, where this has been reported in UK, Italy, and France, and other countries. And they arrange for near qualified students to start working in the health service, as has happened in UK and maybe in many other countries around the world. So if it was the case in general, we know that the same had happened in midwifery. So they were really calling people who did not complete their training. Students were called to help. The obs and gynae doctors also were included to provide care, simply because the severe shortage was existing before the pandemic. So within the pandemic, we lost many of our colleagues in the healthcare, and some of them were really affected, and they were treated and they were admitted for because of the infections. So it was obvious that we will rely on those who were partially trained to help us in providing the care. So getting the help from others or from those who were in the same field but with incomplete training was not enough for the professions. So what they were relying on the technology in providing certain type of care. So what does that mean in midwifery? It means that midwives get up and we have to think carefully and clearly. Are we going to be replaced by robots? Are we going to be sitting and looking at mothers? Or are we going to sit at home and somebody will come and conduct the deliveries and take care of babies? Maybe 2-3 years back, there was the research where they were trying to find out if the midwifery work would be, or the midwifery practice will be computerized. Then we have to think how to not to lose the focus of the mother and babies, and not to concentrate on the computer focus. But the reality right now is saying no. If we have to believe in the coming years, from this year, we have to change our way of thinking. COVID-19 has accelerated the arrival of future work. In times of crisis, where companies need to cut expenses, automations may not be a priority. But one thing that this crisis show us, and that automations matter. So automation matters, which means that people and companies have really to think to use the robot in replacing the humans. What were done. Artificial Artificial intelligence can free employees from more laborious and time-consuming tasks to focus on creative and innovative projects. The technological challenges is how companies will manage the relationship between employee and artificial intelligence, as the latter will replace the need for the certain skills and increase the demands for others. So now it is really an area that we need to think about. Therefore, for workers set to remain in their roles in the next 5 years, they have to learn new skills by 2025. Because it is expected that employers will divide the work between the humans and the machine equally. And we have started that when we did some of the changes in our type of care provided. So we have to be careful here that this invasion is going to come and be part of our profession. We know that due to global economic crisis, job creation is slowing and job destruction is accelerating. So the use of machines and robots is really highly present here. Many companies around the world use technology rather than people for data entry, accounting, administrating duties to cut down and reduce the expenses. COVID crisis and the measures applied to minimize its spread impose that, and more than that on governments. So now our governments are really in a corner. They found themselves in a corner where they have to cut down all the expenses and bring up their economy. So what they will be doing, they will look for such things. During the COVID-19 pandemic, Jerry Jen launched the virtual clinical led, nicknamed Flu, to deliver the clinical services from distance. Utilizing Flu allows the client to continue with product implementations and avoid experience project delays. Clinical services provided by a distance program, including clinical configuration workshop, virtual education classes, and clinical go-live support. So it was a real step to use the technology in providing care to women during the pandemic. As per market and market report, the global artificial intelligence healthcare market is expected to grow from 4.9 billions in 2020 dollars to reach to 45.2 billions by 2026. So if the companies the industries are having these expectations, what is remaining, or what should we do? Should we sit and look at them till they will bring the machines to replace us, or we should have our own plans to come up with our restructure our professions in such a way that it will tally with what technology is trying to invade in our professions. Major factors driving the growth of markets are increasing volume of healthcare data, and we are really suffering from that growing complexity of data sets, intensifying need to reduce towering healthcare costs, improving computing power, and declining hardware costs. Growing number of cross-industry partnership and collaborations, raising imbalance between health workforce and patients, driving the need for improved healthcare services. All of these are really raising, and we are suffering from it. So the finding or the solution for it is ready by the market to come up with those artificial intelligence to be introduced to the professions. Invasion of technology to the healthcare or even into midwifery. Despite the fact that a couple of years, artificial intelligence related applications around the diagnostic or medical imaging and oncology, there was speculations about artificial intelligence and its possible application in the delivery room. So they were thinking in advance for introducing to the delivery room. So what do you think midwives right now will happen if we were really having all this kind of crisis? As the artificial intelligence can change childbirth and make it unique, this is how they market for it. They rely on the fact that there is a vital risk to the mother life during childbirth, and artificial intelligence-based application can help detect diagnosinal beforehand and learn from the analysis. Now that speculations might be closer to the reality because of what? Because of what we experience from the obstacles and the changes. Additionally, decades of research in human factors, restraints against fully autonomous decision-making, as it contributes a poor human situational awareness and degeneration in the human supervisor performance. So if we will have such machines working along with the human, here we might have some of the entertainment level of autonomy will be present, in which the system provides suggestions to be accepted and modified by the human supervisor. So here we might provide better care. If your work place does not have a person or time and a place determined who will what we have learned from the COVID-19, no matter how big and great health institution we have or advanced technology we use to provide care to different segments of populations, and washing, keeping your mouth closed and covered while maintaining social distance were enough to protect yourself, family, neighbors, friends, and colleagues, safe and well protected from infections. So please maintain it all the time. Human life is very fragile. If we did not handle it with cautions, we might lose it because of a very tiny and planned actions. There is no strong person with power or weak with inability. All humans are the same and equal when it comes to stand in front of a tiny virus. So let us work for our safety on this earth without discriminations or dislikes, as we live as a family in one house, not as many families in different houses scattered on this earth. So these are the most important lessons that I have learned as I was trying to share it with all of you. Finally, I can say that a flu pandemic can last for several months. Public health officials may recommend additional community actions based on the severity of the pandemic that limits the exposure, such as flexible sick leaves and telework policies. Therefore, we need to plan for the best, achieving with minimal contact as needed to save life of clients as well as the health team members. Women, women, midwives, and employers across the world will need to consider how best to keep each other safe. COVID-19 will affect maternity care for the foreseeable future, and COVID-19 rates are increasing along with the fact that countries are attempting to adjust to a new normal, bringing concerns about second or third waves of infections. Infection is required. Reshape certain care aspects that have been altered due to the pandemic to be suitable for future of childbirth, considering home birth. New rule guidelines, standards of care, and educations should be developed with the use of innovating technology. Having a good emergency plan in place and developing flexible policies and procedures to accommodate public health recommendation can help reduce infection. During planning process, engage key partners across both public and private sectors and people from the community. Also, the specific details of each plan should be based on the size of workplace and for workforce, complexity of the day-to-day operations, and type of services workplace provided. Properly address in the crisis policy the social adverse effect created by increase in equity, quality, exclusion, discrimination, and global unemployment in the medium and long term. Comprehensive universal social protection system when in place play a much doable role in the protecting workers and in reducing the prevalence of the poverty, since they act as automatic stabilization. And thank you very much.
Thank you very much, Dr. Fatma, for this nice lecture. And thank you for sharing this a lot of information about Omani situation during COVID-19 and the midwifery system there. So my question is, what's the most important point that you can share it for us with the midwifery system in Oman?
Well, if you would like, first of all, I would like to thank all the organizers, all the participants, all the audience who are really attending this great conference in Saudi Arabia. And I'm really proud to hear all of these achievements, especially when it comes in terms of education, in midwifery education, especially in Saudi Arabia, that you have planned and already in planning and which is existed already and what you are going to start soon. When I was looking at that, I really went back to the point where we were facing the same which has been mentioned by my colleague speakers, we come to a point that that midwifery is really a real part of our life, and day by day we need to put. I can say that we need really to have our updated plan for providing care, especially when it comes to the pandemic here right now. We were suffering to maintain the safe of all mothers. We are having great high number of mothers who are affected by diseases or medical conditions, those who need a close monitoring, and we were unable to do that. So a lot of phone calls, consultation were used, but still it was not really a success to maintain that. That's why it's become a very great challenge to us when we think that what we are going to face in the future. So if we will not put such plan earlier, maybe, if we had put such plan earlier, we would have avoided certain things that we are facing currently.
Okay, thank you, Dr. Fatma. But I saw that you mentioned home birth as a plan during the pandemic. So my question is, if there is any policy for home birth in your country, empowering midwifery, you practice that during this pandemic as an urgent plan or not yet?
Well, we did not have any planned home birth, and we did not practice that yet. You know that to have a home birth means that you have to have a well-prepared midwife who is having really a great experience in their professions, so they'll be able to conduct safe deliveries at home. You know, they'll be alone, and for that we need to have at least the community midwife programs where the students are really used to go to the homes and follow the mothers and conduct deliveries. That's why it was really difficult to have the mothers having deliveries. All the hospitals were occupied with sick people with COVID, and the staff will shift here and there for help, but still with the good grace, really, we were trying to have the mothers delivering safely at hospitals only, no more home deliveries. But still,
okay. Sorry?
I was saying that we were getting some cases who were arriving to the hospitals, who delivered at home. So birth before arrival were many during this period.
Okay. So thank you, Dr. Fatma, for sharing this information. And we will go for the next session with Ms. Jawahir. So the next lecture, it will be research study about the Kegel exercising in postpartum women in Saudi Arabia. I'd like to welcome Ms. Jawahir Al-Harbi. She's a midwife and nurse specialist in maternity and children hospital in Al Medina. So welcome, Ms. Jawahir, and thank you for sharing this study with us and sharing this in the Saudi Midwifery Group Annual General Meeting. Thank you.
Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. If you want to prevent anything, alternative must be provided. Through my previous work in obstetric department as a midwife, vaginal surgical dilatation was prohibited, and there are no alternative during a childbirth, which result in many disadvantages. For example, of these, multiple tear, second, third, and fourth degree of the tear. The topic of our research was chosen. It has a relationship with that. Kegel exercise can improve psychological well-being and also facilitate natural childbirth and also to reduce requirement of cesarean section. My name is Jawahir Al-Harbi from Maternity Children Hospital in Al Medina. I'm a midwife and also specialist of nursing. My team this research, Amal Al-Rihali, Nawf Al-Harbi from Maternity Children Hospital in Al Medina Al-Munawwara, and also Farida Muflih and Khulud Ali from Maternity Children Hospital in Abha. under supervisor of our Dr. Ayman al-Sabbagh. Also, this research proved from ethical committee of scientific research in Taiba University, represented by Dr. Khalid al-Jihani, Dr. Hiyam Fathi, Dr. Sayyid al-Rifai, and also Dr. Adghir, and also Dr. Nada, Dr. Muhammad al-Jihani. I want to say thank you for them. And also all thanks and appreciated to Saudi Midwifery Group, represented by Dr. Ru'at Tawili, and also Ms. Taghreed Hawsawi, and Ms. Muna Bukhari, and all its staff for giving this great chance to be one of conference speaker in this 5th annual general meeting of Saudi Midwifery Group. Thank you for them. Let's get to started our research. In our research, we focus on 3 things about the Kegel exercise: knowledge, attitude, and practice of Kegel exercise, especially in postnatal women in Al-Madinah Al-Munawwara in Saudi Arabia. We'll talk in our presentation about the introduction, significance of the study, aim and research questions, also our methodology we use it in this research, contain subject and method, tool of data collection, also the method, ethical consideration, also the statistical analysis. Also, we'll talk about the important result from this study we found it, and also our conclusion, our limitation, and also our recommendation. At the end, we'll talk about acknowledgement and reference. Introduction. What meaning of the Kegel exercise? We can define it as frequent contraction of the muscle, pelvic floor to control the follow urination for strengthening this muscle, also to control or prevent incontinence. Kegel exercise play a role in strengthening this pelvic floor muscle in treatment for prolapse. Pregnancy and delivery may cause disorder in pelvic floor muscle. For pelvic floor muscle like urinary incontinence, fecal incontinence, and also prolapse of pelvic floor organ like uterus and also the bladder and bowel in the woman. That's supported by the layer of the muscle. Also, Kegel exercise, we can say that should be applied for a second half of pregnancy in the postpartum from the 2nd day of giving birth. Also, the Kegel exercise depends on repeatedly of contraction and relaxation of the muscle that shape part of the pelvic floor. The contracted muscle should be in the pelvic floor muscle rather than the thigh and abdomen or the buttocks. Furthermore, we can use it the weighted vaginal conus and biofeedback, and also advice and electrical stimulation can facilitate the performing of Kegel exercise. Now we'll talk about the significance of the study. The most of the previous study have examined the effect of Kegel exercise in both pelvic floor muscle strength and the drain function during the pregnancy and postpartum period. As far as we know, there were a lot of studies that examined the women knowledge and the practice of Kegel exercise during the pregnancy or postpartum in Saudi Arabia. In our study, we aim to assess knowledge, attitude, and the practice of Kegel exercise among postnatal women in Saudi Arabia. Also, our aim from this study to assess knowledge, attitude, and the practice of Kegel exercise among postnatal women in Al-Madinah Al-Munawwara, Saudi Arabia. We have in our research 2 questions. First one, what is the knowledge of women toward Kegel exercise? Second one, what are the attitude and the practice of women toward Kegel exercise? Now we'll talk about our methodology we use it. Our design, we use it in this study, a descriptive cross-sectional study design. Our setting in the postnatal ward in maternity and children hospital in Al-Madinah Al-Munawwara, Saudi Arabia. Also, our subject included confident sample of women who attend the postnatal ward from the beginning of December 2018 to April 2019. The total number of women interviewed by our researcher were 152 women. The subject selected as following criteria, including criteria: age group range from 18 to 45 years. Also, the pregnant with a single fetus, mother who are in the first 24 hours after delivery, and also who is, those whose neonatal will be less than 4 kg in weight, also should be free from complication, cephalopelvic, disproportion, malposition, and malpresentation. Also, the exclusion criteria: women who have urine incontinence, women who get hemorrhoid, and also women who have a present history of uterine prolapse. This is our tool of data collection. We use it in our questionnaire. The 3 tools were used for data collection. Tool 1, structure interview schedule, covered the following 3 parts. Part 1, it included the socio-demographic character of women, like age, and also the employment, material status, education, and also monthly income and background. Also part 2, previous pregnant history, like gravidity, number of miscarriage, and also number of living children, also the type of delivery. Part 3, source for information about Kegel exercise. Tool 2, knowledge of women regarding Kegel exercise. It includes 9 items about the knowledge, like definition, time of start the exercise, benefit for pelvic muscle, also benefit for healing, for incontinence, also benefit for preventing vaginal atrophy, vaginal prolapse, and also uterine prolapse, also for intimacy. Tool 3 covered the following 2 parts. Part 1, women attitude toward Kegel exercise. It included 6 items. Also part 2, practice about the Kegel exercise. Our method, we use it. This study was accomplished according to the following steps. First of all, official letter from the Faculty of Nursing directed to responsible authorities at data collection setting to take permission to conduct the study after explained purpose. Also, development of tool part 1 was done by our researcher after reviewing the relevant and current literature. Tool part 2 and 3 was adapted, modified, and translated by our research to suit the research. Also, subjects were individualized interview by our research. After the completion of data collection, necessary statistical analysis was done. Also, content validity of questionnaire was assessed by a panel of 5 experts for clarity, validity, and comprehensive of questionnaire item. Also, we used a pilot study with 10 participants was conducted to determine clarity and feasibility of the questionnaire and the time of record from each woman to complete the questionnaire. The reliability of tool was tested, and the internal consistency of the tool range from 0.79 to 0.92 indicated that the tool was reliable. Women who agreed to participate in this study and who meet the inclusion criteria were asked to sign a written. Also, informed consent form after general examination by our research, the data were collected through for individualized interview with women in the postnatal ward in maternity children hospital. Also, ethical consideration applied in all stages of this study. The protocol was approved by ethical committee. Also, participants were approached and informed about the purpose of the study before beginning asking to participate. And also, oral consent to participate in this study was obtained from them. The assurance of anonymity was addressed before the request for participation. Anonymity of participant was provided in 2 ways. First way, the participant was asked not to put their names in the questionnaire. Also, they were informed that their participation in this study is voluntary, and they could withdraw from the study at any time if wish not to be participate. Confidentiality and privacy were maintained by data coded to eliminate identifying data with personal information. Our statistical analysis, data coded and analyzed in personal computer using SPSS version 20 software. Also, the graphs were constructed using Microsoft Excel software 2010. Data was described by summary table and figure, descriptive statistical number and percentage, used for describing and summarize qualitative data. Also, we used Pearson coloration was used to coloration coefficient. Here we'll see our results. Figure 1, distribution of participants regarding their socio-demographic character. We found in our study 44.7% of the sample studied women in age group 26 to 31 years old, and also the most of participants were married by 87.5%, and also the half of the sample was employed, and also the more than 2/3, 63.2% of the study women have baccalaureate degree, and also 44.1% have enough monthly income, and also the majority of the sample was from an urban area, 93%. About 93%. Also, this figure we can see distribution of participants regarding their gestational history. We found in our study 67.1% of the studied women have vaginal delivery. Also, 75% of the studied women have multiple gravidia. And also the highest percent, about 85.5% of the sample had no miscarriage, and also in the same time 12.5% have 1 or 3 miscarriage, and also the 50% of the sample have 1 or 3 children. Also, we can see this figure distribution of the sample regarding their source of information. About 25% of the studied women reported that media as source of information, followed by family 16.4%, also by friend 15.8%, and also health worker 13.8%. Also, we can see this figure, correct answer regarding their knowledge of Kegel exercise. We found in this paragraph 74.3% of studied women have correct answer on the definition of Kegel exercise. Also exhibit that 66.4% of the studied women correct answer on the Kegel exercise for pelvic muscle. Also 65% have correct answer regarding the benefit of incontinence. Also, this figure we can see the distribution response regarding total of knowledge. We found in our study 62.7% of the studied women response to the knowledge were correct, and also the same time 37.4% of the studied women response were incorrect. Also, this figure we can see the distribution of mother by overall attitude related to Kegel exercise. We found the most of the studied mother, 72.4%, were categorized as having somewhat favorable overall attitude toward Kegel exercise. At the same time, we found 14.5% of the participants were having favorable overall attitude. Also, we can see this by a chart present that 57% of the studied women have not performed Kegel exercise, whereas 43.8% of the sample had performed Kegel exercise. Also, here in this figure, distribution of participant response regarding their Kegel practice. This paragraph demonstrates that the examined activity of women in the area of performing Kegel exercise showed that 42.8 of women performed Kegel exercise. Among this group, reason that lead to women to use the Kegel exercise, about 38.5 of the sample recommendation from the doctor to practice of Kegel exercise after birth. Also, the 30.8 of the studied women for a prevention of purpose, like a prevention of incontinence. Also, the low point, 9.2, having urinary incontinence. Also, the frequency of Kegel exercise, we found 60% of the sample performed the Kegel exercise 1 or 3 times per week. Also, while 32.3 of the studied women performed Kegel exercise daily. And also we can see this paragraph distribution of sample regarding the position of performing Kegel exercise. We found 56.9 of the study women was performed Kegel exercise in lying down position. At the same time, 43.1 of the studied women performed Kegel exercise in sitting or standing position. Also here we can see the distribution of the sample total score for practice toward Kegel exercise. It was found that 38.5 of the studied women had correctly practice of Kegel exercise in sitting or standing position, while 29.7 of the women had incorrect practice of Kegel exercise. Sorry, have a correct practice of Kegel exercise lying down position. Here we can see this table. We use it person correlation to correlation between general character and the total score of knowledge and practice. As the table showing that the employment and miscarriage inversely correlated with women knowledge, and also the Kegel exercise knowledge was correlated with women education and background with correlation. And also regarding the women practice of exercise, the practice was inversely correlated with age and positively correlated with type of delivery. Also here we'll talk about our limitation we face it in this study. Among the limitation of this study is low response rate. There were no financial resource and dealing the approval from the chosen hospital for conducting the study, which lead to shortage of the time that we found it to distribution and collection of our questionnaire. And also the time was insufficient to collect the sample that we wanted. Also our conclusion from this study, it can be indicated that the sample reported media as their source for information regarding Kegel exercise. Women knowledge concerning the Kegel exercise in postnatal period is reasonable, and also their attitude was favorable. Mother had poor practice of Kegel exercise. Our recommendation from this study, the programs for health awareness in Kegel exercise should be conducted by a health worker to enhance knowledge and practice that will contribute positively to maintain the mother adhere to Kegel exercise, which improve their health status. Also, mother should be informed and trained to Kegel exercise probably by educational course. Future study similar to the current study can be replicated in large sample that will contribute to drawing conclusions that are more defined and general to large population. Also acknowledgement, all thanks and appreciated to all these who helped us in this research, especially Dr. Hiyam, Dr. As-Sayyida, Dr. Dua, Dr. Iman, who directed us for our long period of work in this study. Also, I like to thank my friend in Maternity Children Hospital. Also, thanks go to all mothers who participated in this research and cooperation with us. This is our reference.
Thank you very much, Ms. Jawahar, for sharing this lovely studying for Kegel exercising. It was really fruitful, and I hope this Kegel exercise, it will be a more frequent common for all mothers. So my question is, how you think we can improve and implement more Kegel exercising and let the woman be more accessible for this correct practice?
How are you, Huda? First of all,
Hi, how are you?
by educational course, of course, in antenatal, also in OBD, also in primary healthcare, can be improved when with the course of educational about the Kegel exercise, and should be first of all learn the mother how to the anatomy of pelvic floor and also the function of the pelvic floor, and then to train how to do the Kegel exercise.
You, as a midwife, you have a contact with mothers and pregnant ladies before delivery, or when the exact time that you give her the proper education to target a good a practice for Kegel exercising. Especially like we know that Kegel exercise, she need to know her physiology, her anatomy better, so she can practice this to prevent the high rate of episiotomy, to empower the midwifery good skills during birth and labor.
Yeah.
So you have perinatal classes to introduce this Kegel exercising?
Oh, until now, I don't have anything, but I want in the future. And also, I hope to take our recommendation from this study and apply it in reality. This I hope.
Okay, thank you. Thank you very much, Jawahar. Thank you for all attendees today. And thank you to be a part of our lecture. You need to add any comment? Jawahar? Okay, thank you for today. Thank you for joining us for our 5th annual general meeting for Saudi Midwifery Group. Hope that all of you attending, enjoying our lecture and our presentation. Thank you and appreciate for all speakers that attend this event, and also for all the organizer team. You really do a great job. For our attendees, to guarantee your CME hours, you need to don't miss to fill the evaluation form that will be sent to your registration email ID to obtain this credit hour. The conference has been awarded by the Saudi Commission of Health Specialty. Thank you, everyone. It's really honored and a pleasure for me to meet all of you speakers today. And you make this event really valuable and fruitful for all, and to empower midwifery in Saudi Arabia. Thank you all. Thank you, especially as I mentioned before, it's really amazing organization team. Thank you, Dr. Arwa. Thank you, Saudi Midwifery Group, to give me this opportunity to be the moderator for the 2nd day. And good luck for all midwife and for all best for the mother and baby in Saudi Arabia and on all world. Thank you, everyone.